Hi, good evening. I don't know if you can hear me well. I do hope so. But this internet does difficult sometimes. So I apologize for people host. Sure. I actually talk about I'm going to talk first, but I'm going first. My name is Adrian Waterman, uh, anesthesiologist, and also critical care or intensive school as well. Also in the field of pain management. I must declare I also sit on the band exec, but I will declare early this disclaimer that sometimes some of the views may not reflect exactly that of the plan. And I'm grateful to Dr. Linda Williams as well as to also a few others, including my husbands and Anthony Brand as well, in terms of having discussions earlier about this topic euthanasia. But it just remains sometimes a very divisive topic. So
Good
I'm
evening,
grateful to
everyone.
hear.
I just want to apologize profusely, but I could not have avoided being caught up at work, and I'm covering the light and power rate hearing, and things got a little dicey. So please forgive my lateness. So I want to welcome you all to this in another series of Man Talk, and getting right to the meat of the matter. For those who are joining us here, the subject is, should euthanasia be legalized in Barbados? And with us, eminent panel to represent the church. We have Reverend Dr. Cicely Athel Horsford. She is head of the Barbados Christian Council. And we have from BAMP, the Barbados Association of Medical Practitioners, Dr. Adrian Waterman. And we have the former Attorney General of Barbados, Adriel Brathwaite, and I know he's has a close, how should I say, affiliation to this issue, and he will let it all unfold as we have our opening remarks. So let's start with ladies first. Reverend Athel Horsford.
Before you came in, Dr. Adrian Waterman was speaking, so I give way to him so he can conclude.
Okay, well, I'm sorry about that. So continue then.
Oh, sorry. I guess I will say that I was just making introduction. Sorry, Mr. Emmanuel. I was just introducing myself, basically presenting the plan, but I also want to reflect that some of you do not always reflect that of the council. We do remain a diverse group, so sometimes we do have been looking towards that. So I just wanted to clear on that. So do not take everything as this is a representation consensus of doctors. And I make some things.
Okay, so you were kind of breaking up a little there. I don't know if you're close to your mic. When we get around to you again, kind of project, get a little closer to your microphone. So let's hear from you, Reverend.
I am the Reverend precisely the word, Cicely Athel Horsford. For the past 18 years, I've been telling Barbadians what my name is. And I would appreciate you call me Reverend Cicely, and you will be my friend. This topic is not one that I ever thought I would be on a panel to talk about. And so I've been doing some research and asking persons from the church. And the term normally implies an intentional termination of life by another person at the explicit request of the person who wishes to die. And hearing that euthanasia is, it pulls at my heartstring to say that who gives us the right to lawfully take somebody's life? That's what it is. It is active euthanasia. it is involved causing the death of another person. I would have preferred us to talk to the wanton killing of especially our young men here in Barbados and how it is affecting families and so on. However, I will stick with this one and say that I, in particular, in the heart of should we legalize it here in Barbados is a question that should not even be out there. I imagine that you are suffering from a disease that is terminal, debilitating, and very painful. Should you have the right to die when you wish, rather than live in a continued agony? Should your doctor be legally free to help you to take your life? Perhaps by prescribing whatever drug, pills, or whatever injection, or should the law forbid this? I trust that we can have an in-depth discussion on what it is, why should it be legalized or should not be legalized, and where are we with all of this as church. Thank you.
Thank you. I just want to note, just to let you know, Reverend, that we have discussed just what you suggested we should discuss. So this Man Talk is a series of discussions on these hot topics. So we've actually discussed that issue of these violence and imprisonment and where the guns coming from. You know, we go way back. So we've discussed a lot of subjects over the years.
Okay.
Yes, so this is just one
Fair
of
enough.
those things that we got around to. Mr. Brathwaite.
Hi, good evening, everyone. And when Emmanuel invited me to be part of this panel, I said yes without thinking about it. This is one of these topics that will take lots of discussion if ever Barbados contemplates having assisted suicide. If I look at the definition of euthanasia, it says that the painless killing of a patient suffering from an incurable and painful disease or in an irreversible coma. Synonyms are things like mercy killing, assisted suicide, physician-assisted suicide, mercy release, happy release, etc. I know that this will be a very emotional topic. I know that the church will have its position. As someone who spent the last 50 of my 60 years in the church, I understand the church's perspective. When I first started any kind of conversation about this, I simply thought, what would I want for myself? If I was dying and there was no hope, would I want to continue, assuming that I was in pain, would I want to continue? Or would I want to have the option, if I so desire to end my life? And when I came to the conclusion that I would want that option on a personal basis, I therefore formed the position that if I thought that I would want to have that option, I should be allowed to have that option. And it should not be a case of the state saying, no, you cannot, because this is the same state who in many countries across the world hang people or put them to death for murder. So I think it's a bit hypocritical for the same state to then say to me, no, you cannot have the right to die at your choosing. Given that, as I said, given the definition that I gave in terms of that, you know, this is someone who's in who's in pain. The doctors have said, look, there is no hope of you living. You will die eventually. I had the experience a couple of years ago of visiting one of my friends in Trinidad, who was in a hospice for a couple of years. And it was one of the saddest moments of my life. And you know, and the family, of course, continued to visit her in hope. And I thought then, as I do now, and as I would say, that I truly would like the option, if I ever reach that stage, to determine whether or not I should continue to live, and the state should not take that right away from me. So that's my initial thought. As I said, it's a personal position, and so I, you know, and if it's my, you know, I'd be hypocritical to say that I have a personal position, but legally I'm against, you know, I'm legally I'm against it, or morally I'm against it. But I'm saying that, you know, I began from a position, what would I want for myself? So that's my initial comments. Thank you.
Okay, so at this point, what we want to do is kind of delve deeper into this issue. And I want to get a better insight from the church. Let's start with you, Reverend, as to what is your church's position on this, if there is one, and what is your personal position, and why do you take that position? And if your church has one, why did your church take such a position? You're on mute.
Right. My internet is unstable and it will go in and out and off completely at times.
Okay.
What is my personal position? Why would I take such a personal position? Well, I am against the state killing people for murder. I'm against that. I'm against suicide. And I can hear Adrian, as he said, that visiting a friend and the sad state, and so he would want to have the option of terminating his life because there is no hope. But for me personally, I am anti-death penalty. I am now making the position clear that I am against euthanasia, and legalizing it is more so I'm against that too. I personally, now the church's position, I think we are against capital punishment. We do not support the death penalty. Yes, people perform the vicious act. And yes, the Old Testament scripture says an eye for an eye and a tooth for a tooth. But we believe that, yes, there is a different way, and don't kill you because you killed somebody. In the case of the debilitating situation with your health, in constant pain, and the incurable state of the disease, we believe that, yeah, you're going to die. Wait until you die. Don't allow or give the option to the doctors. It is understandable, though tragic, that some patients suffer terribly, but in the midst of the pain, there is something that you can teach others. And for me personally, I would want others to learn. I would want somebody else to understand where I am rather than I would be asking my doctors to take my life.
Okay, so does the Barbados Christian Council have a position on this?
I'm not sure because I have not discussed it with them. I now know that I'm going to put it on my agenda just for discussion to hear the various churches' position on it. I know where I am from and the Moravian perspective. And so I'm talking from that particular perspective.
Okay. Okay, thank you so much. Dr. Wardman? Yes, unmute.
Sorry about that. I can fully understand where the Reverend is coming from in terms of her beliefs and where she stands exactly. I just wanted to add, let me start from the nerdy point of view in terms of euthanasia. I know it was just defined by Mr. Prophet. So just to add, there are different approaches to euthanasia. There's whereby you have a passive approach whereby you withdraw treatments or withhold treatments for the person in terms of sustaining their life. And there's also active, which is done by some countries, including Switzerland, Belgium, if I stand correct, whereby you actually administer a medication that unfortunately leads to the person's demise. Also within euthanasia, to mention, there are other categories such as voluntary, where that person makes a decision to have euthanasia. Just as Mr. Braffett had just mentioned, you make a conscious decision, and a conscious decision that is an educated one. So you're well informed when you make that decision. There's what we call non-voluntary, whereby the person unfortunately was not able to make that decision. The person may be in a coma state, for example, or the person may have a mental illness which does not allow them to be cognitive or able to make that decision. And then there's the last one, which fits in the line of, you can say, homicide in terms of murder, whereby it is involuntary, whereby you actually refuse to have euthanasia. And basically, that's something I can tell you definitely no doctor in Barbados will condone. I was glad that you had asked the question in terms of where the church had stand. And I know people will be wondering, I have mentioned this before, like in terms of where BAP stands. Now, one of the things is that our president basically like to make sure she have a quite appreciation of the consensus of the island in terms of when we address any issues. So it's not that these decisions in terms of coming up with policies and practices are simply made around a round table of doctors, etc. We exist in a community and we are part of the community of, for, and by the community, I would say to a degree. The other things that I wanted to mention in terms of euthanasia is that what people sometimes have to understand is sometimes not only the aspect of suffering with severe pain that is one of the issues, but there are other aspects to it. The psychological aspect where people sometimes feel that they have given up. Sometimes people feel that they are a burden on the family. Sometimes people feel that they can't just go on, they can't handle this anymore. They just feel like they're losing their dignity in terms of dying. And I must say, it's a very complex issue, and we try to understand it from all point of views. The other thing too, I must say that is basically you'll meet is sometimes doctors sometimes wouldn't support the practice of euthanasia for different reasons, be it religious, for example, maybe it's even cultural for them too as well, or personal experiences, which all influence us.
So we also have our own moral tensions that we face when dealing with such an issue too as well. So you may even have, if it, let's say it had to be legalized, you may have some doctors that will still oppose it, but however, what you will have is what they call like a really make decisions in terms of making sure that you have the care and attention by other people that will carry out your wishes too as well. And just to emphasize, especially in terms of voluntary, it must be that the person have made that conscious decision. That conscious decision, it must not be influenced by others. It must be that person's own decision in terms of if they want to proceed with such a case. And one of the things, what they have done is, what people try to do is move away from the word suicide because it has a different connotation. Suicide basically is associated with more a person does not have a terminal illness per se as such. Well, in the case, people are now more using medically assisted assistance in dying as a term rather than doctor assisted or physician assisted suicide. I will continue as I don't want to be grabbing everything, so I'll let the rest.
No, so I'm not sure if I'm clear that did you mention whether BAMP has a position on this?
I did indicate that BAMP has not put a position on it as yet. They're still reviewing like the policies and protocols, etc. In discussion. When it is basically prepared, then Dr. Williams will then release what basically the consensus of BAMP.
What is Dr. Okay.
But for right now, she believes that yes, we should have as much a debate about it as possible.
To your knowledge, doctor, do you know of any instances in Barbados where patients requested that?
No, not exactly. Although I work in critical care, and I must say, in critical care, you actually see sometimes a higher incidence of people unfortunately dying, or you may come across people that unfortunately may have terminal illnesses. Oncology actually may take much higher numbers, but I've not heard anyone specifically requested it consciously. I have come across patients that may have cried out in agony. I've met such a case, and actually, to mention, actually somebody that was very religious. I actually heard crying in pain and suffering when they had their terminal illness. It was most unfortunate.
You are, I believe, an anesthesiologist.
A word that bites even my tongue.
Yes, anesthesiologist, yes.
And in this or
yes. So how would that, because that has to do with numbing or controlling pain or managing pain, including managing pain?
Yes, it is true because, and then by extension, doing like chronic pain too as well, which would involve patients that have like severe pain due to cancer, intractable pain, where see pain that is very difficult to manage. So as anesthesiologists, we operate under our remit is management of pain, both in terms of the operation, in terms of having operations, or sometimes we assist other doctors in certain procedures that can be extremely painful. And then there's a branch of us that will go off in terms of dealing with patients that have chronic severe pains or patients that have cancer pain. And cancer pain is sometimes a very difficult pain to manage because it not only involves your tissues, like what people might experience like osteoarthritis, but when cancer sometimes does is it actually get into the nerves and it can actually drive people like almost like feel like they're insane. So we assist in managing that too as well. And palliative care. We also have a role in palliative care as well.
So do you think that there's some impact, some help that your field of study or practice can do with patients who are going through this kind of suffering and who may want to leave this earth?
But yes, because I must say that thanks to one of the doctors here in terms of I've been pushing palliative care. I see her as I call it the mother palliative care. She may hate me for calling her name, Dr. Graves, but we are definitely involved in terms of palliative care too as well, because sometimes pain cannot be managed by simple over-the-counter drugs. And even some of the prescription drugs that you can obtain via the pharmacy are not enough to manage sometimes people with pain. So sometimes we have to enter into the realm of, we have to use certain techniques, sometimes even going off into the area, almost like mini surgeries to try to manage a person's severe pain. But you must admit that sometimes even these techniques are not as efficient as we want it to be, because sometimes the drugs that we have to employ or the techniques we employ, can cause their own adverse effects. One of these adverse effects or side effects of the drugs that you can have is whereby people become extremely sleepy or sometimes lose consciousness. They can actually stop breathing too as well. So although the intent is to manage the person's suffering, sometimes it extends where actually the person's life can be compromised too as well. So we have to consider these effects when we are doing palliative care. And there's a mention of recently of palliative, putting people in a palliative coma. And that's whereby sometimes you're using the medications at dosages, or unfortunately for the person, the medication actually puts them into a coma when you're trying to treat their pain. Recovery from that might not always be permissible. But in this case, just to mention, but in these cases, this is whereby your intent is to treat the suffering as best as you can. The intent is not to lead to death. It's an unfortunate consequence of it.
So we will come back to you later. Mr. Brathwaite, do you want to add to this aspect of the discussion with respect to managing pain? Do you think that that might suffice or help in any way?
Well, let me just pick up on something that Reverend Sicely mentioned, which is that this is not a case where doctors make a decision and say that they recommend that this person's life be ended. And the frameworks that I looked at quickly, it's the patient themselves who makes that decision. And in most jurisdictions, if not in all the jurisdictions, that in fact that the law requires the fact that the patient is advised of alternatives to death. Palliative care is a good example, where in fact that the patient sits down with the medical practitioner and explores all of the options, and then once the court is satisfied or once the law is satisfied that in fact that after they've been exposed to all these options, they've made a decision and the conscious decision that they want to be put to sleep, then the law so allows. So it's not a case where, the doctors say, look, you don't have a chance of living, so why don't you consider, death? There are cases, of course, from my reading. I read a couple of articles in Canada where it was suggested that medical practitioners or personnel, recommended to the patients that they might consider assisted suicide, inverted commas, because of things like the cost of care on a daily basis, and that they'd be a burden on the family, etc. You need to guard against issues like that. I think if you have a well-structured environment in terms of ensuring that there's integrity in the process, that in fact that the patient is given the best possible care and advice, and still makes that decision, and as I said, makes the decision, a conscious decision that this is the way that they wish to go. That's what it should be. I believe that the state and the church over the years, and it continues, have placed themselves in positions or in matters that we need not be so passionate about. A good example is that we will always have prostitution, as far as I'm concerned. It was before our time, and it will be after our time. Yet we take the position that it is illegal, and everyone knows that, you know, if you go on the Garrison, that you will see the ladies, or if you go by Corey Street, etc., you know, you see where they operate. And the church has its position is wrong, the state has its position is wrong, but it continues. And what happens? These women are exposed, and men are exposed to the elements, exposed to abuse, you know, because we've taken a position for religious and or moral or other reasons, and negates the fact that it happens and will continue to happen. So we're very hypocritical about it. And so we need to have these kind of discussions. And I was surprised that you chose this particular topic, because I don't believe that as a country that we started to have the conversation. But I'm glad that you did, because this is the kind of thing that we need to have a chat about. Now, if I go back to Canada in terms of my reading, it's been suggested in one article that I saw today, that in fact that is very highly abused. You know, persons have used the legislation to commit suicide. So it's not a case where they're terminally ill and they're in pain, you know, etc. Like I suggested at the beginning. They're frustrated. They have, you know, mental or other issues. They believe that the world is against them, and use this as, you know, as a vehicle to exit the world. So in those instances, those persons need help, and we have to find some mechanism that in fact that we can give them the help that is required, so that the law, if we ever reach that stage, isn't abused, as is suggested in some jurisdictions. But I'm going to say it for the last time, but I do believe that if you are speaking, or if you make a decision from an informed perspective, and you have the proper legal framework, the options should be available.
Right. So you answered one of the questions I wanted to ask. If tomorrow we were to legalize this, what are the fears of abuse, as you mentioned? And I wanted to take this question to, may I call you Cicely, please? Right, because this formality sometimes is a little burdensome. Yes.
Sure,
yeah, could you,
that's what you call me normally.
Okay. Could you zoom in on that issue of abuse? And the other question that I want you to put in the back of your mind also is, if it were left to you, what would you do in a situation where someone you went to visit as a priest and you saw them in suffering badly, and they asked you to do something to help them to go? So there's two questions.
I agree with you, Mr. Bradford, when you said that the church and government does put themselves in things that they really ought not to. I would not use prostitution because there are some churches that assist with the persons who are involved in prostitution. We don't even use the term prostitution anymore. They call them sex workers, and we also fight for their rights and so on. I personally have been involved in some of those areas. So I'm not sure if it is hypocritical. I know though that where euthanasia is legal, that some doctors assist with it. And how does that work with their Hippocratical oaths? Get to the question that you asked, Emmanuel, about if I visited someone who is terminally ill and that person asks for my assistance in dying, I know that I don't have any right whatsoever to assist. And so I would be able to say that upfront and with the person. I know for a fact that they're going to die. I also am aware that they have a time span, because most of the time there is, and I know the law in one of the states of the United States, it must be that the doctors give you about 6 months to live or thereabout. So I also have a working time. I would be there with you. I would be talking with you, even though sometimes that wouldn't help. I would encourage you to take whatever medication that is prescribed. And of course, my good old prescription of prayer would come into play. For me, that's what I would do. That's where I would be. And I need to look again at euthanasia and the whole gamut of it, so that if at any time we start the discussion, I would be a little more informed.
Okay, so you gave me a segue, a cue for my next question that I want to put on the table for all three panelists. And I know that it might not be fashionable to put this on the table, but I'm going to put it anyhow, because we're talking about alternative options to euthanasia. Well, this is part of the mix. Prayer. I want to find out from all three of you if you believe that prayer is an alternative that would work in terms of keeping the person alive or bringing him back, restoring the health.
If I may respond immediately,
Yeah.
is that I don't see it as an alternative. I see it as part of my whole being. And when I go visit, and mark you, I have visited persons who I know. In fact, I visited a lady 3-4 years ago, and she was up for surgery. I waited in her room at the hospital. I saw them wheel her out to the theater, and 10-15 minutes later, they wheeled her back in. And they said she was too old for the surgery, so the advice was take her home, make her comfortable, and she will die eventually. 4 years later, 4.5 years later, she's still alive. I'm not saying that is the outcome of many of the persons, but yes, I prayed with her. Yes, I prayed with the family. Yes, I've been pastor to that family over the years. She is now 103 years old. And 7, 8, 9 months. 103 years old and 9 months. Friday would be 10 months. And she's still alive. She still speaks to me and questions me about my going ins and outs. Prayer, not an alternative, but it is one of the tools that for me as a Christian I use. That is fundamental to me. And most of the time in the situation of terminally ill patients, it's that God's will be done. I pray that God will ease the pain. I also pray that his will be done and help us to accept whatever his will is.
Dr. Waterman?
I must agree that in terms of managing, and I'm coming from the medical aspect, certain physiological diseases or impact pathologies on people, that there's a very important component, the spiritual aspect along the psyche. It is very impressive and it does have an impact on some people. I cannot quantify, I cannot qualify how it has that impact, but it does have an impact. But however, from a statistical point of view, and I say broadly, sometimes it does not work for everybody, which is really unfortunate as such. But one thing we appreciate, and I may bite my tongue on this word, the existential crisis that people will experience when they believe that death is inevitable. And some people feel prepared, some people don't feel prepared. And that's where we see very important, whereby we appreciate different specialties, be it the doctors, the families, and the religious, let's just say elements, basically coming in to assist too as well. And one of the things that I must say, and I know you were highlighting that in terms of that the person went on to live for quite a period of time, is that no doctor or no one I know can predict when a person will actually die. Yes, we do it on, and I would say the hard word statistics that you might hear people say, well, we expect another 6 months, we expect another 6 weeks, etc. These are based on observations, but they're not true facts, 100% true facts, because there are some people that have for some reason, they go on for quite a bit. And we do find sometimes that people that keep their faith, very strong in their faith, sometimes are able to survive through. It may not work for every single case, but some people do. And if you got to really get scientific, it's not surprising in some cases, because as I have to tell some of my patients, your mind, for example, produces a lot of chemicals that what we have done in the real world has mimicked. We mimic those chemicals in terms of making them hopefully stronger, even down to drugs like, I'm going to mention one that is becoming quite popular now, cannabis. Your body produces a similar compound. And that's how we are able to use cannabis, for example, in the treatment of chronic pain that some people experience in terms of suffering. But forgive me for this. I wanted to say something in reference to what Mr. Braffett said earlier, and he was discussing Canada. But I would like to say this, that there are safeguards that are very importantly placed to decrease the chances of people abusing the use of euthanasia or medically assisted assistance in dying. So I just want to mention this quickly. People sometimes would consider this, you have to be over the age of 18. You have to be of full mental capacity. You have, when you make that decision, you have to make sure it's not coerced or under duress. Basically, you also come back to that decision. Like some places will say 10 days later, some places will say 15 days later to ensure that, you know, this is what you have decided as such. And your disease, your terminal illness must be diagnosed and relative prognosis by separate independent doctors. So it's not, so that helps decrease the chances of people using it as a method of suicide, basically. So if the person presents with suicide, looking at that as a mental illness that they have, then they, of course, will have to refer to the appropriate specialties. There's no intent to murder anybody, but in agreement with what Mr. Braffett said too as well, all, of course, alternative possibilities, usually discussed with people. And some people, they will have it on their books in terms of euthanasia, but they will still continue on their course with palliative care and spiritual healing as best as they can. So it's not that they're fixed in that making that decision. They can change their mind at any time as such. It's not that they have a one-way street. But back to Reverend, I do agree in the aspects of spiritual healing, regardless of what religion or denomination or whatever you have. I believe something that's proved very important. And that sometimes is part of the dying process, whereby people can address the issues or unsettled issues that they had during life. Because sometimes that is one of the biggest things that people sometimes have in fear of dying, where they're going to next. And we don't know. Well, from a scientific point of view, we have no empirical evidence of it, not to say that it doesn't exist. That is from a scientific point of view.
Thank you. Adrian?
Well, as I said at the beginning, I grew up in the church. I still worship. I consider myself to be on a spiritual journey. I believe in prayer. My Bible is close to my bed. If I can't sleep for whatever reason, I might just pick up my Bible, and I find it's very comforted, and off to sleep I go like a baby, etc. So prayer is a very powerful tool, and so I don't think that I would say no, that in fact that it doesn't play a role, because your faith sometimes gives you the strength to do things that you don't believe that you can do. Mm-hmm. Where you and I might disagree, however, is that I do not believe that the God that I worship is involved in every aspect of everyone's lives on a daily basis. In other words, that he determines that you die tomorrow and I live on for another couple of days, and that Adrian lives until he's 99, etc. I don't believe that. When my third son died, for example, at 14, I had a crisis of faith. And one of the things I remember is how annoyed I was by the people who came and said to me, he's in a better place, God knows best. I couldn't reconcile that this God that I worship, that they worship, that he knows best, that you take my son at 14 years old. So it's easier for me to believe that God is not involved in, as much as we tend to want to portray in our daily activities. That's why we have freedom of choice. We make our decisions. If I leave here and I'm going down to St. Philip, I swing left and I get there safely. I swing right and I get an accident. I made a choice if to go left or to go right. I don't believe that God tells me, swing right and go and get into an accident, or swing left and go away from the accident. But prayer is a very powerful tool. And I've seen, and heard of instances where it's made a tremendous difference in terms of people's lives. And those of us of the Christian faith do believe in the power of prayer. So yes,
Okay. So before we get to you, audience, just one more question. Dr. Waterman, do you know if in your profession is a conscious effort to kind of carry out any study to link the power of prayer or spirituality with scientific measurement, so to speak, of people's health or the outcomes in severe situations like, where you have a terminal illness?
I don't know offhand if there's any. I must say, I'm trying to remember. I remember I given us a talk on spirituality a while back, and if I stand correct, it would have to be based on some some scientific background as well. So they have to have some people that will try to see the correlation or a relationship between the two that exists. However, I cannot quote offhand for sure, but I will not be surprised if there have not been studies out there. The rigors of the study, however, in terms of how well you can say that they show truth, sometimes can be a bit tested, because sometimes it's very hard to sometimes make a connection between two, because the measures are sometimes very subjective as such. And that's why I was highlighting earlier in a little sense that, for example, one of the things that you will hear some people say, the absence of evidence is not necessarily the evidence of absence as such. And for right now, we have no way of testing certain parameters. I can't do the afterlife and come back and tell you. Only one person did the afterlife as far as I know. And we're celebrating Easter next year. So I can't answer that.
Okay. It's time for your audience. I want you to not all jump in at one time. Your time to contribute, make your comments or ask your questions on this issue. Don't tell me that you're all silent and that you don't have any contribution to make. I'm sure you do. I'm sure questions going through your mind and you want to say something. Now's your opportunity.
Did I answer the question?
Yeah, you can ask.
I have to ask, why Barbados, where do you find that certain issues, like, for example, this topic, euthanasia, the use of cadavers for organ donation, why haven't we just addressed these and we are waiting for so long? What are we waiting on? And the reason why I raise that is because when we have, the pandemic, and I'm going to walk into muddy waters now. This is from me. This is not from that. When we had the pandemic, the crisis with COVID, and I was discussing with some people that this was actually time for us to look far more closely at advanced living wills, advanced directives, where people are able to make a decision about their future in terms of their management. If, for example, they wanted to be placed on ventilators or not, if they wanted to be resuscitated or not, or certain measures that they will have in terms of sustaining their life. And I really thought that pandemic was supposed to wake us up to address these issues. And the reason I say that is it may sound a little, how should I say, more about coming from a doctor, but if the way I was looking at it is that if that pandemic gotten really super serious in Barbados, for example, we had deaths going over, like, let's say 100 a day, and the requirements for critical care was extremely high, we would have had an issue in terms of who we could have taken care of as such. And you had people out there that have already made a decision, for example, given that they know that they may not be able to sustain themselves afterwards, or they will survive, for example, some of the medical procedures or the burdens that they would have been induced. And they would unfortunately sometimes end up on the ventilator and not being removed. Well, you had people that would have had a better chance not being able to access that medical facility. Sorry, I had to drop so much food for thought.
No problem. I see, Adriel, you had your hand up.
Yes. Adrian, I think that the issue here really is that we need to talk about these things as a country. When you spoke about cadavers, for example, I remember Gabi's song, which goes back however long ago, etc. And we all dance and, etc. But Gabi was wrong. The reality is, from my perspective, is that we need to talk about these things. We something as simple as making a will. Some people don't make a will because it means that they have to contemplate dying. So something as simple as, why did you not make a will, or have you considered making a will? I'm going to get to it. Because in the back of their mind, they don't want to come to that decision that in fact that we all have to leave this earth. Maybe Barb, maybe Bam, is going to have to put their hands up and let's have these kind of discussions across the country. This is 2022. My children are more enlightened than I was, and their children would be more enlightened than they are, hopefully. So at some point in time, as a country, we're going to have the conversation, but we can start it now, and like yourself, I could have only hoped and prayed that we didn't reach the stage where doctors had to make a decision in terms of, who to care for and who to let go. During the pandemic has happened in several countries across the world. So it's a very, very difficult position to place physicians in, but it's also the kind of thing that through education that we can take ownership ourselves and not place physicians in those kind of positions.
Yeah. I hope you can see I'm not in an agreement.
No, but that's all right. Thanks.
Right. So back to the audience. I don't want to call on anybody, but I'm sure that you're here to make a contribution as well as to listen. So your contributions are valuable.
Okay, my question would be just out of curiosity. I guess it might have to go to the former Attorney General. What changes in terms of laws and stuff will have to be put in place should euthanasia become legal in Barbados? Just out of curiosity.
Well, I mean, we'll have to put the legal framework in place to ensure that in fact that persons who assist are not charged with murder or not charged with with infringing any law because it becomes a law. But as I said, we'll have to look to see what works in which jurisdictions and how they work, etc. And we don't need to reinvent the wheel. There's Canada, there's the United Kingdom, there's the Netherlands, Switzerland. There are several countries across the world that had these discussions and have the legal framework in place. So whereas I can't tell you exactly which laws that we'll need to have a look at, I can tell you that there are legal frameworks out there that we can look at and decide what suits us best. If I go back to Canada by example, they actually contemplated reducing the age below 18. They actually are contemplating, from what I was reading, the fact that even persons with mental illness, that they can be considered if they indicate that they would like to be put to sleep. So the frameworks are out there for us to have a look at when we want to have the conversation. But we need to have the conversation, and as you know, we are pretty conservative as a society.
Yeah.
So people just need to be enlightened and understand that this is not a case where physicians are making a determination that they're going to put X or Y to sleep, but in fact that the individuals themselves are making informed decisions about their health care.
Yeah. Yeah. You're happy with that response, Marcia?
Yes.
Any other contributions? I'm sure you have. What are your thoughts on euthanasia? Is it something that you would support?
I'm not sure what my thoughts on it are at this time. They're very mixed. I don't know if I was I'm very mixed. I'm all over the place because I'm not for, I'm not against. but I'm still not in the middle either. So it's kind of.
Okay. All right.
Emmanuel,
So
if I can, Adrian, you will note that in fact that the reading here suggests that the majority of cases over the last couple of years in Canada, the underlying request came from the fact that the persons were suffering with cancer, which I think it said about 76% of the requests came from persons suffering with cancer. And I believe that in your presentation, Adrian, you suggested that in fact that often that, you know, there's a lot of pain involved, and thus you can see the link.
Yeah, sorry. Yeah, I agree with sir. Yeah, because unfortunately, well, you know, probably a lot of us have been already touched in some way by a family member, or unfortunately our own selves too as well, with cancer. But you see, the problem with cancer especially is that it don't sometimes remain restricted to one area. And when you get a, for example, attacking not only the bone, severe bone pain, it sometimes infiltrate the nerves. So the person have a continuous pain, a relentless pain going on. And then there's even the impact on the brain. And for a loved one or a caregiver to recognize when this person is deteriorating, they're screaming in pain and agony constantly, or they're totally delirious, or even seeming like, I use the Beijing favorite word, gone mad. I can understand where you were coming from earlier when you began speaking much earlier about seeing your friend suffering. And what people sometimes don't understand is, or some people don't appreciate that, sometimes that in itself is almost like what we would describe as like a traumatic stress disorder. Seeing a person going through that then impacts upon you. I'm not using it correctly in the correct psychiatric word, but it definitely will have its toll. And then it creates a fear or apprehension in other people too as well. So I can see why people would more want to be considering in terms of management if they're entering these so-called terminal illnesses. But just to mention, I know you mentioned earlier in terms of the reduction in age, and I know that we're talking about mature minors, and I in a way can understand why people may also consider the reducing the age in terms of a person that can understand, a child that can understand what they're going through, and also seeing that child agonizing. But as I said, and I agree with you 100%, is that it's not a doctor's decision in terms of implementing a medical assistance in there. It is whereby the person makes that decision. I want to highlight that, because I would say to the Reverend, we don't say the Hippocratic. Well, I don't say the Hippocratic oath, because that Hippocratic oath is a bunch of deities that I don't really support. But we definitely have an onus of entering a covenant with the patient, and beneficence is what we definitely believe in. Do good to the patient, do no harm, preferably. Those are some things we definitely consider. So I appreciate everything you just said, Mr. Bradford.
Precisely, do you think these are the kinds of issues that the church need to take a role in playing in enlightening the peoples? I know, yes, you will have your core issue of doctrine and theology, but these are all part of your life, your everyday living, issues like this that impact the lives of people in a real way. Do you think they
Of course, we need to, if it requires, we need to start the discussion, because it affects people in the church. It affects everyone, one way or the other, and we need to start the conversation. We really need to start it, and I'm happy that you, the men, started it like this, and how other groups can also discuss. And I trust that we can go forward so that it becomes a national discussion, a national issue to deal with, to talk about. We are good at finding faults, identifying what is wrong, seeing where people are not going right. However, there are times times when we need to, and most of the times, need to look at issues and speak about them and come to a resolution so that others can benefit and others can grow, so that others can even come, like Marsha, come to that point to say, I believe this and this is where I can go. But the conversation needs to be started.
I agree.
Anybody from the audience want to chime in here? Okay. Pastor, you want to make a contribution here? Pastor Chrissy?
Can you hear me clearly? Are you hearing me clearly?
Yes, I'm hearing you.
Sorry?
Excellent.
You're not hearing me? Yeah, just chime in and make your contribution.
I was listening quite attentively to all three panelists. And I remember when my grandfather was ill, I believe he had a form of cancer in his stomach. And we were living downstairs and he was upstairs. And the pain that he suffered was of such that he would drop his foot onto the ground, onto the floor, and he would hit the floor for hours on end. And so whether it was in the morning or the evening or whatever time you were at home, you just would hear this thumping sound all day, all night. Medication was not working, nothing was working. And the truth is, when I experienced that, what came to my mind was, what could be done to put him out of this pain quickly? And this discussion that we are having now is bringing those thoughts back, because at that moment, I wasn't thinking as a Christian. I wasn't thinking as somebody who was at that point in time thinking about being for or against euthanasia or anything. I was just thinking as a grandson who saw his grandfather in pain and wondered if there was not a better way to alleviate that pain rather than having him go through that pain day after day after day. And Cicely spoke about, Reverend Cicely, I think I got the name right, spoke about this dichotomy between wanting somebody to live, but understanding that given the pain that they're in, their condition might not improve. And we talk about learning from that condition. But the question is, when somebody is in such pain and unable to, for instance, unable to communicate well because of the pain, what are they teaching us? What are we learning? Is some people would, like Mr. Bradford said, that is for some people, that is a means of walking away from the faith, because sometimes we are very callous with how we approach those situations. And one has to keep asking those questions, because at the end of the day, what happens in our end of life situation is as important as what happens when we are enjoying life, because that could make or break the next person who is close to us or even ourselves. And as we discuss this matter, I continue to think about what my grandfather suffered, and I continue to ask the question, wasn't there a better way for him to have a graceful exit from this earth without having to experience that level of pain?
Oh, what a story. Wow. He who feels it knows it. Anybody else here want to?
Emmanuel, which
Yeah.
brings me to this comment that I want to make, which is that one of the things that I think, again, as a church, as a society, that we need to put more emphasis on is how do we offer support, and I mean emotional in particular, to caregivers. You know, my mother at 95, you know, mom used to, you know, she might swear once a year, but she's at the stage where one day she might very well curse me out with some words that I didn't know that my mother knew. And the next morning, she is a gentle, angelic 95-year-old mother, who kisses me and hugs me and so happy to see me, you know, etc. So following on from the last intervention, that's also something that we need to do, that we need to look to see the impact of illness on the caregivers, on the family members, etc. If you read about the number of elderly who are left at the hospitals, etc., automatically we think, well, you know, what a bunch of wicked people leaving their mother or grandmother, you know, at the QEH or wherever healthcare facility. But the other side of the coin is that maybe it is in those cases that there are 1 or 2 people who don't know what else is there to do. That they just cannot cope and believe that that's the best thing, that's the best course of action for their loved one and for themselves.
These are some really serious questions, because I think it's like some people get emotional when they hear these things, but they don't dig deeper to find out why these things happen. And you made the point that maybe they just can't cope. You know, they just cannot cope. And that this is one of the issues that we probably might look at later, the impact that illness, and especially severe illness, can have on the caregiver, and not only on the caregiver, but the relatives and family. Because when you go in the hospital and you see your family or your closest relative with tubes all over the place, and they can't even recognize you, and they're just looking there, just waiting to die, as it were, you know, it is serious impact on them. Yeah. You want to say something?
Yeah, there is also the caregivers I thought of myself when you have members at the hospital and the doctors calling you, please come because the person is on the way out. And that is a hard thing on me personally, because here you have the medical side of it calling on me to come and do what you have to do in the last. So when you are going to look at how do we help caregivers, how you help them to cope, caregivers also would be pastors and those persons, the nurses and the doctors. They too need looking into.
Yeah. Dr. Waterman, what I want to ask you, what kind of impact you've seen families had on families from your experience and your practice, that these severe illnesses have had on families?
Well, you definitely know it will be quite a range of emotions that you will experience, and including from like some people would embrace what is going on. Some people would be angry for many different reasons. And sometimes that anger is directed at the medical profession, including the nurses too as well. Some people, for example, is being totally denial of what's happening. And then there's the conflicts. I sure that Mr. Bradford will know these, the conflicts that arise as soon as someone is dying, whereby people see opportunity, the selfishness in some individuals, some families, and even some caretakers too as well. But I agree that overall that definitely it's definitely a tremendous impact upon us all. One of the things I just want to mention, this may sound a little selfish coming from our part, is that sometimes people don't appreciate that sometimes the doctors too as well, and the nurses that are involved in these people care, they also take a psychological hit. Because sometimes we do meet some people, for example, that you know, for some reason they get on your skin in such a good way, and you sort of enjoy seeing it, you enjoy interacting with them, and sometimes even with the family too as well. And then sometimes watching this when they're on this trajectory towards their terminal illness, or they experience suffering that you can't get over, sometimes it leaves you too traumatized. And sometimes it takes us a while sometimes to get over it. But because of how our system functions and the pressure is placed on us, we have to shred it off as best as we can and get on with the next, you know. But it definitely has a toll on more, not only the family, not only friends, but it also have a toll on those that take care of these people inside of these hospices, inside of the hospital too as well, and even like those out there in the community. And sometimes we still need our priest or pastor or rabbi, or for our own spiritual healing after these events or exposure to such. On a small little note, I just wanted to mention something that is quite mentioned in terms of one of the drugs, morphine, which is a painkiller that we use. And there's a lot of people there that have a stigma attached to it, that the doctor has given our family and give him or give her morphine, they can kill the person. And the truth be told, I mean, morphine has been a very useful drug. And one of the problems that they have had with morphine is whereby in the past, because of the fear due to lack of education, it wasn't used effectively, or it wasn't used in the correct way. But you will see in some cases, especially with patients that suffer with cancer, that it is one of the drugs that we will use in an attempt to manage a person's pain. But one thing I must indicate, like anything that we do, any procedure, any drug that we give you, there's always the possibility of a complication, and we try to manage those as best as possible. Just want to highlight that part.
So how much of this you can take over time? Have you got about 10 more minutes? And how much of this morphine, how much of this drug?
Well, morphine, like unlike some other painkillers, don't have what we call a ceiling in terms of the amount that you can take. And what to mention, for example, paracetamol or Panadol, as Belgians effectively call it, that drug has a recognized maximum dose, and sometimes that dose has to be decreased depending on the condition of the person. Because if you use like more than 4 grams of paracetamol per day in the average person, you can lead them to having liver failure and irreversible liver failure, which can kill them. Drugs such as like another drug is like cataphan or Voltaren that people may know it as, that also has a ceiling effect whereby there's a maximum dose of that drug that can be given. These drugs I talk about in use of pain. So when we reach the maximum that we can give for the patient, what happens is if you go past that maximum, then you're entering into the area whereby you're causing the person more side effects and more harm than good. Now, in the case of morphine can be increased to quite high doses. But however, as you increase the dosage of morphine, you are increasing the possibility of these side effects. So it's not that we will say, for example, a person may have we say on average, a person may require, let's say 10 milligrams of morphine. But then you may find that some people actually require much more because of the pain and the pain that they are experiencing. And just to highlight what the previous Reverend had said in terms of unfortunately his grandfather, I think for us, unfortunately, past, and we're getting better at it, that pain management was not as great, or palliative care was not something well practiced in the past. And probably most likely where your grandfather was stumping his foot is because he's trying to use one of those techniques that we do when we experience pain, whereby you're trying to use to block that pain by tapping your foot and creating a distraction from that pain. That was probably why he was tapping his foot so often. But it's really unfortunate that back then that he couldn't be offered better management. I'm not saying necessarily euthanasia. I'm saying that in terms of palliative care. And hopefully that can make him much more comfortable.
Do you want to say something?
Yes, I wanted to ask a question to Dr. Waterman, and I think he touched on it briefly in the end. But I am aware that among us, there are some people who are required to take doses of morphine, sometimes daily, for various medical conditions. My question is there, well, sorry for Dr. Waterman, can you tell me of any situation where those dosages have had to be reduced because the person improved, or from your practice, that is something that continued for as long as you could remember?
Yeah, that's a very good question. And yes, there are some conditions outside, I would say, well, sometimes we divide it into cancer and non-cancer pains in which you may use morphine. What they have been trying to do these days is to move away from using the opioids for non-cancer pains as much as possible because of the possible side effects that people may experience. There are cases whereby people who would have started on these opioids and grouping morphine as part of these opioids, that includes pethidine. People in the case of scenarios whereby people have sickle cell disease and they can have severe bone pain too as well, almost like cancer pain. And they can require quite a bit of opioids in terms of their management. Now, thankfully, as we improve in our methods of pain control, we are finding other agents that we can use to hopefully decrease the amount of the opioids that person may require, or actually sometimes remove totally the opioids that they require. So even in cases of back pain, I, for one, for example, try to avoid using opioids in the management of back pain. And if patients present to me and were on opioids and they were on high doses of opioids, I also try to use alternative techniques. And alternative techniques doesn't necessarily mean drugs only. Sometimes it goes from the same use of spirituality, it goes from the use of physiotherapy, it goes even the use of aromatherapy, and aromatherapy has its uses too as well. So non-conventional methods of pain management I will also employ in association with other specialties to help to hopefully decrease the pain that the person experiences. And just to mention this quickly, and there's something that probably some of my patients may see me doing a lot more, the use of a psychiatrist/psychologist. It does not mean that you have a mental illness, that you're mad or you're crazy or that your pain is not real. And even in the case of managing cancer patients, psychiatrists can be very important in terms of teaching people or helping people to use their mind in terms of helping to alleviate pain. And you'll see that in the cases of distraction, whereby distraction works in terms of helping people decrease their pain. Sometimes the use of group therapy and other approaches, cognitive behavioral therapies, which psychiatrists are very good at. Sometimes we use them to help manage pain. It has nothing to do that they have a mental illness such as madness. And sometimes, however, they will help decrease the anxiety that some patients have, because some patients then focus on pain. And if you focus on pain, then you aggravate the pain actually more, and the depression patients have. Just to mention that. So I appreciate that question.
Okay. So what we want to do at this point, if you don't have another question, Pastor, is to ask each one of you to make your parting, I don't want to use the word short, your parting remarks, starting with
There was this guy who went.
on mute. You're on mute.
Thank you for the opportunity to be a part of the panel and to share in this way. Thank you for giving me the opportunity to go and do some research on euthanasia. We all value the opportunity of living in a free society. We also recognize that there are rights and rights need protection. But we must balance this against responsibilities and restrictions if we are to be truly free. I want us to continue the discussion on this topic in every area of the country, in church and outside of church, to get the views of everyone, and so that we can be able to make a positive decision and have a positive outcome, because the decisions we make have implication for us as a nation and as citizens to live by. Thank you very much for the opportunity, and thank you, fellow panelists, for helping me to look deeper in this area.
Thank you so much. Adrian?
Yes, like Reverend Saisty, thank you, Emmanuel, for inviting me, and certainly listening to the discussion has been enlightening, and I'm driven to do a bit more research. Adrian, I hope that we meet sometime. It's been very refreshing to hear you. Not necessarily as a patient, but here's my final comment, which is that we guarantee our people under the Constitution a right to life, right to property, etc. I think we should equally guarantee people the right to die with dignity if they so desire, because for sure we will all die. Thank you.
That's it? Okay. Doctor?
As Adrian too as well. First, I must say I really appreciate being invited. It's quite been an honor to be with the rest of the panel. It's great to be enlightened by both those in the legal and as well as the religious field. And I know how basically Barbados is well connected as such. I hope I did honor to the association. I hope I did honor to you too as well, Mr. Emmanuel. I am glad you put up with me. As such, I hope that I can offer some educational points, and I'm always open to be educated too as well. And I do believe in the importance of the church. I do believe in the importance, most importantly, the importance of the person's right to choose appropriately. And I hope, as you all have mentioned, that we definitely go forward and that we don't only make these talks. We are fantastic as Barbadians giving talk, fantastic for getting the next 2 weeks too as well. So I hope we can action it. And if we do action it, besides looking at other models, and I agree we don't need to reinvent the wheel, but we can improve upon the wheel for ourselves. And I really appreciate it again. And thanks to your audience too as well. I hope it didn't intimidate anybody.
Thank you. Thank you so much. I must say that each one of you made invaluable contributions. And we learned a lot. You gave us food for thought. And I'm sure I will tell you, I will not stop here. And I'm actually been thinking of a big thing in terms of getting this as a national discussion. I can't say what I'm going to do right now, but I have ideas. And I'm sure that you will be invited. So just stand by, and so we'll move forward, because this shall not just be a talk. We're looking to make this something big, something national, because these are issues that touch our lives, touch our families' lives, touch the church, touch the schools, the homes, every institution, every aspect of society. So again, I want to thank you all, and I want to thank the audience for joining, and I know that you have received good food for thought, and that you will be part of the process as we go forward. Thank you again so much, and